case, the patient received ibrutinib and treated as one would as standard of care, which is continuously until the time of progression. However, after approximately 3 years on therapy, he was demonstrating evidence of progression by both his symptoms as well as palpable disease in the lymph nodes and the spleen, and then he was confirmed to have progressive disease. Because he was confirmed to have progressive disease in this case, in the second line setting, he would meet indications for transitioning fairly quickly to the next line of therapy because the disease was progressive. In other situations, if patients, for example, had received chemoimmunotherapy in the front line, they obviously would not have been receiving this continuously and might have been off treatment for a period of time until you saw the return of the CLL. Or in some cases, now with the approval frontline of fixed duration therapy with venetoclax and obinutuzumab, those patients are treated for 1 year fixed duration and then stop treatment. In both those latter cases, when patients have cessation of therapy, are monitored until the time of disease relapse. In those cases, patients may not need to start their second line of therapy right away. That is, during the patient's routine follow-up, you might notice that their white count and lymphocyte count is starting to increase, but they have no symptoms, or they might have slow return of the lymph nodes, but again, are not large or symptomatic. In the second line, then, it should be pointed out if patients are already not progressing on continuous therapy, that you monitor again for the IWCLL indications for treatment that were discussed before, as patients might not on initial relapse need treatment right away. On the time of relapse, though, it also would be important to know they should receive full workup, including consideration to resend some of the prognostic markers, namely FISH testing, chromosome testing, and TP53 mutational analysis. Again, the results of those tests would not necessarily change that you need to start treatment right away on the relapse. However, patients that might not have had the highest risk markers, such as deletion 17p or TP53 mutations at the time of their first treatment, may be found to have this at the time of relapse. That could inform several conversations with your patient, including consideration of clinical trials if found to have this higher risk disease. In this case, though, I want to go back to the fact the way that ibrutinib or other BTK inhibitors or many B-cell receptor downstream targeted therapies are administered, that is continuously until the time of progression. So in this case, the patient does need treatment transition fairly quickly. And I should also point out that because they're on active treatment, at the time of progression on ibrutinib, one should not stop the medication abruptly until you've had time to review with the patient and plan accordingly for the next line of therapy. That is because even though they're progressing on the treatment, it may still have some effect on some of the CLL cells, and stopping it quickly could result in a flare of the disease or an even more rapid progression. In terms of options in the relapse refractory setting, or specifically for this patient with resistance to ibrutinib, multiple trials in the relapse refractory setting have shown an overall survival benefit to targeted agents. They would not consider, as there is no evidence for transitioning these patients back to chemoimmunotherapy. Amongst the other targeted agent options in the relapse refractory setting would be venetoclax, the BCL2 inhibitor, either as monotherapy or in combination with rituximab, idelalisib with or without rituximab, which is a PI3 kinase delta isoform inhibitor, and if this was the third line, also duvelisib, which is a dual gamma delta inhibitor. If this patient was being transitioned to either of the targeted agents I mentioned, either the venetoclax-based regimen or idelalisib, would have treatment planning for that patient, and again, not stop the ibrutinib until you were ready to start the next line of therapy. Just like in the frontline setting, patient-specific factors are important in the treatment planning, namely also the patient's comorbidities. For example, this patient with their chronic kidney disease had reduced creatinine clearance. This is important because if venetoclax therapy is chosen, patients are at risk for tumor lysis, and this is part of the dose ramp up and monitoring. Tumor lysis risk and the need for hospitalization during the initial dosing depends on the disease bulk, but also patient-specific factors such as the renal dysfunction. In terms of choosing a PI3 kinase inhibitor as the next line of therapy, the toxicities that one must be mindful of that can develop with treatment of these agents can be both early and late onset symptoms, such as a colitis, which can lead to diarrhea and dehydration, as it can be very profound. Patients can also have other late onset autoimmune-like conditions, such as increases in their LFTs or pneumonitis. Many have looked at baseline clinical factors that might predict the development of these agents, but it is not entirely clear, for example, that patients with baseline dysfunction, such as lung disease, are necessarily at higher risk. All patients should be considered at risk for the development of these toxicities. In any case, if this patient is transitioned, for example, to next line therapy, we sometimes draw from clinical trials that have specifically studied agents after ibrutinib progression. These studies are fairly limited in patient number to date, and that's largely due to the fact in the timing of the development of these agents, and that many patients on the initial relapse refractory clinical trials had been treated in earlier settings only with chemoimmunotherapy. There is one series using venetoclax in patients following ibrutinib therapy. This is approximately 90 patients, and patients were treated with venetoclax after ibrutinib, either if they stopped ibrutinib due to resistance or if they stopped it due to intolerance. And here the response rates were approximately 60% for the entire population. Again, however, one must be considerate of tumor lysis, and in this case, with the patient's reduced renal function, if they were receiving venetoclax, I would counsel the patient on their higher tumor lysis risk and consider hospitalization for the tumor lysis monitoring.